in a bit. Alright, so we're going to pick up from where we left yesterday. We talked about biologics, the monoclonal antibodies. There were 4 of them hitting specific interleukins or a receptor target. So you have to know this, okay? Expect at least 2 to 3 questions specifically from that. It's very straightforward. Just know the drug and the target. I mean, it cannot get better than that. Omalizumab is an IG antibody. So if you have omalizumab which binds to your IgE cannot go and prime the mast cell. There is no degranulation of the mast cell to release histamine. Histamine is a cause of infection. Everything is at peace. Alright, so that was your first drug. We talked about IL-4 and IL-13 antagonist. Do you remember what was it? IL-4 and IL-13. Dupilumab. Right, so that's kind of like the drug which is going to prevent IL-4 and IL-13 to go and bind to the receptor targets over here and then prevent the inflammation. And then we have IL-5 antagonists. What were there? There were 2 of them. Pembrolizumab and Reslizumab. And then we have to remember that they were IL-5 drugs which can bind to IL-5 and drugs which can bind to IL-5 receptor. Make sure you know what is what. Okay. Alright. So you do a quick knowledge check here. We have all the drugs listed here which we discussed and their targets on the right side. We just have to match. Starting with first, benralizumab. What do you think is the right option? And eosinophil apoptosis. Because it's an IL-5 target, eosinophil is not primed. That will prevents the apoptosis as well. Omalizumab, straightforward. What else? And if you bind to an IG, what's happening? Mast cell degranulation. Moving forward, reslizumab. IL-5. Dupilumab. IL-13. And reslizumab. IL-5. Okay. So please go back, remember, recall, do whatever, but please remember those targets because they're very important. And that's the only thing you have to remember for biologics. There's nothing much to it. I just have like the last knowledge check on the biologics again. A patient with mild persistent asthma and aspirin exacerbated respiratory disease. Remember from the last class, I'm not going to tell you the answer, but we discussed that there was one drug which was specifically used for aspirin-induced asthma. Don't look at the choice, tell me the answer. Aspirin-induced asthma. We discussed one drug. No, don't look at the choice, tell me the answer.
It was Jose's question.
Jose is missing here.
Yikes.
Alright, so there will be one from this class. Montelukast. It's Leukotriene modifiers, but yeah, so I can give the benefit of Montelukast, but again, there is also another drug out there. Can you name that? It's a Leukotriene modifier.
Oh, the C one.
Yep.
Yeah,
What is it? No, I can't help you. Tell me the answer. Xylitol. Okay. Right. So that was basically a drug used for aspirin-induced asthma, and then we also have Montelukast. Montelukast can also be used for allergic rhinitis and any of those seasonal allergies in addition to asthma. Over here, which Leukotriene modifier inhibits 5-lipoxygenase? Moving forward. A patient with high eosinophil count and frequent exacerbation is started on benralizumab. What is the primary mechanism? Benralizumab. It cannot be 4 and 13 because that is dupilumab. So what is left? It cannot be IG because that's omalizumab. So then what is left? It cannot be beta 2. Does it do anything to beta 2? What's that? B. Inducing eosinophil apoptosis. Alright. You will be expecting such type of questions. And now, this question is just inside right now, but you will have to answer this type of questions among all the other 49 questions. It will become tough. Alright. So the only key for you is to know as soon as the drug comes to your mind, the target. It cannot get easier than that. If you are going to be fumbling on understanding the target or remembering the target, you're going to lose it. Okay? Dupilumab, what's the target? I'm not going to read the whole thing. What is the therapeutic effect of this treatment? That's it. Alright. Thank you.
All right, so getting into pediatric dosing, same table, different answers. They don't necessarily need to focus on it, but understanding that with pediatrics, especially in step 2, are going to be on the ICS table. Is there a lava there at all? No. Okay. Where do we see lavas introduced to pediatric patients? 3. Okay, so 3, 4, and 5. However, the reliever option is still the most preferred, the ICS plus Remodal. Okay. Okay. However, when we get back to this, remember it's the same table from before. So making sure that you're reading the right growth for your pediatric patient, which in this case would be 6 to 11, not 12 to 18. Okay? So again, being able to make sure that you can read these tables, that you know your generics, and that you know how to calculate that ICS dose to determine the low, medium, or high. Okay? All right, asthma management in pregnant women. So the goal in pregnancy is to treat the asthma the entire pregnancy. As we know, some conditions we have to stop certain medications while the patient is pregnant because those medications are more harmful than beneficial. In asthma, it is more harmful to not treat the asthma or to stop the ICS maintenance inhaler than to continue. Okay? So, treating it with that ICS-containing drug reduces the risk of exacerbations during pregnancy. Cessation of the ICS during pregnancy is a significant risk factor for exacerbation. What lab are we looking for to determine if our patient is pregnant? HCG. So make sure you check. Okay? There were several questions on that class. I once realized the patient was pregnant. I was like, oh, this is easy. We only have 3 options to pick from. Very easy. So always making sure you're checking for those labs. As I stated before, the benefits outweigh the risk to continue that maintenance inhaler for those pregnant. Okay? Any questions on pediatric service pregnancy? All right, so medication therapy management. The preferred treatment is always per the stepwise approach. So that's step 1 through 5. We always need to follow that. Track 1 if we can. Track 1 if we can. And we want to control the symptoms and make sure that we reduce as many risk factors as possible. Okay? What are some risk factors we talk about on the first day? Smoking.
Exercise.
Risk factor.
Risk factor.
Exposure to the allergen is a risk factor. The allergen itself is a trigger. Obesity.
I'm trying to remember.
Pregnancy. Stress. Exposure to allergens of any kind or pollutants, but pollution is a trigger. Make sure we review those. Okay. We also want to consider the patient's preference. So what are their individual goals? They want to be able to play with their grandkids. They want to be able to run a triathlon, whatever the case may be, want to take that into consideration. And any concerns they have about medications. So even if you're a patient, you have a pediatric patient and their parent has concerns about the ICS, and you're like, it doesn't cause growth suppression, they're going to be okay. If they do not want it, and they're adamant about that, we need to honor and respect that preference as well. Okay? And then considering some practical issues. So again, going back to that inhaler technique, considering the cost. What does their insurance cover? How much can they afford? If they can't afford it and it's the best option for them, they can't afford it, are they going to take it? No. So if we don't give them something they can't afford, then what are they taking? Nothing. Okay? And then considering adherence as well. So you guys have been probably wondering, well, when did we go from step 1 to step 2 or step 3 to step 4, et cetera, et cetera? First, we need to review this response. So remember at the beginning, we talked about the PPCP, we had a little cycle, and the last step was to review the response. So we want to see what is the frequency of their asthma-related visits, and what is the severity of those visits. So how often are they showing up to any healthcare facility, whether it be a doctor's office, urgent care, emergency department? How often are they showing up for those, and how severe is the exacerbation once they arrive? Okay. The initial treatment, after we start them on, whatever we start them on, we want to follow up in 1 to 3 months. So 30 to 90 days. Some controllers take about 3 months for their full benefit to be seen. What do you guys know about SSRIs and SNRIs? They take like 6+ months. So not that long, but it does take some time to see whether or not it's working. Which is why you can't determine their asthma severity until after they've been on treatment for at least 3 months. Okay? If they're undertreated or if they're more severe, it may take a little bit longer for us to see some sort of benefit. So if you're like, oh, just come back in a month and a half, depending on how severe they are, or if you don't know correct, you might want to extend that time to give them time to respond appropriately. Once they are controlled, we typically follow up every 3 to 12 months. I usually see somewhere in the 9 to 12 month range, but 3 to 12 months is what I would say. Okay? After an exacerbation, within 7 days of being discharged. So when you think about discharge counseling, we're going to change your inhaler, we're going to put you on this drug instead, you're going to go home on this, you're going to stop taking that inhaler. We're going to follow up within 7 days to make sure that you get the new inhaler, it's going well, how are you feeling, are you still having symptoms that are bothersome, et cetera, et cetera. Okay? So 1 to 3 months after initial treatment, 3 to 12 months after that, 7 days post-discharge. Make sense? Alright, so when do we step it up and when do we step it down? We want to have some initial considerations. So what's their adherence for in that side of control? Are they using proper technique? Do they have uncontrolled comorbidities? So remember that comorbidity is a risk factor. Good. Do they have persistent environmental exposures? What does that mean? Persistent environmental exposures.
Things that trigger.
Things that trigger are happening on an ongoing basis. And do they have an inappropriate diagnosis? Maybe it's not working because they don't have asthma. So sometimes we need to consider that as well. The goal is always the lowest ICS dose for the most optimal asthma control. Why do we want the ICS dose to be as low as possible? What was the concern we had with ICS? Thrush. Okay. What else? So we are concerned about the HPA access suppression, but what was the other? Osteoporosis.
Yeah.
Okay, so as much as we can, we want to decrease the ICS dose. How long is a patient going to be on a controlled medications for their asthma? For a lifetime. So we are constantly putting them at risk of osteoporosis if we don't keep that ICS dose as low as possible. Okay? So you want to be able to connect all these dots back to something different. So when do we step it up? For short-term step-up, so this is increasing the ICS therapy for 1 to 2 weeks. We will do this if they've had viral infection, if it's currently allergy season, or if it's initiated by the healthcare provider, HCP healthcare provider, or by the patient. That's going to be based on the written asthma action plan. So in this case, this is when a patient would modify their dose on their own with guidance from the healthcare professional. Okay, we're going to talk about how you pick that dose in a bit. We're going to sustain that step-up therapy, so that means that we're increasing the ICS for a minimum of 2 to 3 months. Some patients just fail initial treatment. For those who did, just didn't really give them enough control. Maybe we put them on step 3, but it should have been on step 4. We have to rule out other causes prior to increase. So if we go back to this slide, we want to make sure that all of this is addressed first. And if it's still not well controlled, then we can consider sustaining step-up therapy. Okay? After we step up that therapy, it's almost the same as initial treatment. So we need to follow up in 2 to 3 months. Once they've been on it for a while, we want to make sure that it's still working. And if so, we go back to that 3 to 12 months on that same dose. Okay? If they're not getting a response after you have increased the therapy, this is another time you're to consider that alternative treatment. So a question a couple days ago, when do we alternative treatment when we pick track 2? If the track 1 treatment options didn't work for our patient, which is what we always do. If first line therapy doesn't work for whatever reason, then we go to second line therapy. Right? When do we step it down? So we want to consider this if they have had adequate asthma control for at least 3 months. So their asthma has been well controlled, they haven't really needed their rescue inhaler at all, they've been taking their maintenance inhaler with proper adherence, and they've been well controlled at least that 3-month mark, we can consider stepping them down. If they were on step 4, they've been well controlled for 3 months, we can consider going down to step 3. Okay? The goal is to find a minimum effective treatment, but we never want to fully discontinue that ICS or the ICS combo. So if they're on a combo, which hopefully they are, we never want to discontinue it altogether, but we do want to find the minimal dose that's most effective. We want to encourage the patient to continue it. So we always tell patients that say, oh, I don't need it because my asthma is well controlled. Your asthma was well controlled because you were taking same thing with blood pressure. Oh, I don't need to take it because my blood pressure is fine. It's fine because you were on medication. You stopped the medication. That's where you really got there. That's why you put it in meds. Sense? And then patient-specific approaches. So we want to consider an appropriate time to decrease that dose. We don't want to decrease the dose if it is allergy season, if they're in a high stress season of their life, if they're pregnant. We want to keep everything as it is. If they're in just a regular day in and day out, they've been well controlled for 3 months, that would be a more appropriate time to step down there. So final week, probably not the best time. The holidays, probably not the best time. Okay? Provide the patient with a written asthma action plan. So I'm saying it a lot, I'm just going to do it in just a minute. We want to stop one medication at a time, starting with their non-ICS. So let's say they're on ICS plus LABA, they're also on montelukast. We want to remove the montelukast first and keep that ICS plus LABA dose the same. If they're well controlled on that for 3 months, then we consider decreasing the dose of the ICS plus LABA. Okay, we never want to adjust or change the ICS plus LABA first. We want to leave that one to the end and go as slow as possible. Okay. When we're reducing it, we're thinking of how much do we reduce it by? How do we know? 25 to 50% every 3 months is appropriate in most cases, so I'm never going to test you on that. You need to maybe go from high dose to medium to low. Okay, and be able to calculate what that dose would be. Any questions about step up or step down here? Does this make sense? Does it seem pretty practical, intuitive? Alright, so KS is a 14-year-old who reports to the clinic and is currently taking Symbicort 2 plus twice a day. She says she sleeps better but has woken up twice in the past month in coughing fits. She takes the bus to school and has recently started playing soccer. She usually has to use her albuterol in the middle of every practice, she says. Unfortunately, as a result, KS was sent home from practice early 4 times in the past 2 weeks. The past medical history is allergic rhinitis, ADHD, and asthma. The medications include Adderall, Symbicort, and albuterol. What is the best consideration for KS at this time? So how old is she? So she's a child and an adult. Okay, and what do we want to do?
Her asthma is uncontrolled.
Okay, her asthma is uncontrolled. Maybe. When is she getting her inhaler? It should be before, but she's using it in the middle. So what's the first thing we should recommend to her? Pre-treatment with that reliever inhaler. Okay? You could probably also educate, recommend to the doctor to discontinue the albuterol, recommend Symbicort for March. Maintenance and reliever therapy, and then use the Symbicort for pre-treatment. But yes. Okay? Yes.
She also mentions allergic to grass. If she wants to.
I don't disagree at all. I'm like, wait a minute, this allergic rhinitis, we have indication without medication. So some could argue, let's start on Montelukast, but again, how old is she? And in the real world, does that make her a pediatric or an adult? A pediatric. So what was the black box warning with the Montelukast? Neuropsychiatric events, which are more severe in pediatric patients. So we should start her on some sort of second generation antihistamine as well, plus the pre-treatment. Okay? She returns to the clinic when she's 16, so we've missed a follow-up, but it's okay. And states she feels great. She made varsity soccer and pre-treats with albuterol before every practice. On average, she has mild symptoms once a week that she's able to control with breathing exercises. Her medication regimen now has removed the albuterol, and they've decided on Singulair. Hold on a minute. What changes would you make now? It's still soccer season, but we stuck down. Remember, determine an appropriate time to do that. So if she's still in the throes of playing soccer, you want to step down her therapy right now. No. So what would we do? Leave it as it is. Leave it as it is. This is good. Counsel on neuropsychiatric events to the parent and move on. Okay? So you see how like those two small changes could probably make a huge difference, which also plays into your quality of life for the patient. Okay? Any questions about this? Step up, step down. Good? All right, so now let's talk about managing an exacerbation. What did we say an exacerbation was on the first day? What's another word for exacerbation? An asthma attack, acute asthma. Good. So they can also be considered a flare-up, an attack, exacerbation, acute severe asthma. Good job. These are episodes that are characterized by progressive increase in symptoms. Remember the first day we talked about symptoms are variable. Sometimes the frequency changes, sometimes the severity changes. In an exacerbation, the symptoms are progressively getting worse, like in real time, like you've been watching. Characterized by shortness of breath, often reducing chest tightness, and progressive decline in lung function. What Dr. Mohammed talked about with lung structure and anatomy, what's happening in asthma. Airway remodeling, does that recover over time? No. Which means that we need to address exacerbations as quickly as possible and prevent them as often as possible. Because once lungs get worse, they do not get better. The best you can do is prevent them from getting even worse. Okay? So what are some common triggers for an exacerbation? The same ones for asthma. Viral respiratory infections, allergen exposures, food allergies, outdoor air pollution, seasonal changes. So this can be when spring is coming or returning to school in the fall that like it's starting to get cold. Mine is actually probably the worst in December. Okay? Also, poor adherence to the ICS and inhaler technique. So maybe while they're in the ED is not the best time to ask them, well, how often are you missing your inhaler? That's not the point right now. It's just so much free. We'll talk about that later. But we do need to at some point talk about that adherence to ICS because that's what's going to help prevent exacerbation. Alright? Some factors that increase the risk of asthma-related death is the box on the slide, the star on it, bookmark it, whatever you have to do with this. Probably one of the most important things when we're talking about managing exacerbation. Okay? Poor adherence to their medications as a whole. Not taking their inhaler correctly. Not having an asthma action plan. So, I know, I keep saying it, I'm still talking about it, but it's coming. Not currently using an ICS at all. So they're only on Montelukast. I do not know what's going on with that. But they need to be on an ICS. Overuse of that solids. We talked about that before. Using more than one canister a month. How often is an insurance company most likely to pay for it? Every 30 days. So if they need it more often than that, they are at risk for an asthma related. Okay? Currently using or recently stopped an oral corticosteroid, OCS, oral corticosteroid. They have a history of pediatric or psychosocial problems and diseases. Having a food allergy in a patient with asthma. How many of you all know what I'm allergic to? Pretty much all fruits. Tomatoes, strawberries, lemons, oranges. If it's citrus and you make a refreshing summer drink from it, I'm probably allergic to it. So I'm just adding to the list of things for that. Major risk factors include previous history of intubation and mechanical ventilation, or hospitalization or emergency care for asthma within the past year. So I'm safe on that part. Okay. I would probably also consider not being on some sort of allergy controlling medication if the patient also has allergic rhinitis. Because you can kind of consider that allergy medication as part of their controller therapy. It's not a controller inhaler, it's not a maintenance inhaler, but it is part of their maintenance therapy. Okay? So make sure that we're treating the whole patient so that we don't end up here. Any questions about this? Alright, so with management, we have self-management. So again, the patient can manage their own medication therapy at home with an asthma action plan. We're going to talk about primary care management. So think about provider's office. If you want to go to ambulatory care, same thing. And then emergency care medicine. So that management has to be urgent care and emergency department. Okay, so let me one at a time. All right, asthma action plan. If you have a calculator, I highly recommend that you take it out. If you want to use your phone calculator for today, you can use that as well. On the exam, you'll have to use the exam software. Okay. All right, so this is a little bit older of an asthma action plan, but I like that it has the colors. It's designed for pediatric patients because most people are diagnosed with asthma as a child. Okay, so it's supposed to be something that's friendly for the child to be able to kind of do it with a little bit of help from their parents, because we want them to have as much autonomy as possible. So this is based on their symptoms as well as their PEF, peak expiratory flow. It helps patients to recognize and respond appropriately to worsening asthma. So this is, what do I do when I can't breathe? What do I do when I'm short of breath? How much more of my medication do I take and when do I stop? That is essentially what an asthma action plan is supposed to do. Okay? The plans are going to vary from patient to patient. So no plan is ever the same. Sometimes we'll increase controller therapy, sometimes we'll increase reliever therapy, sometimes we will add on an oral corticosteroid. And the patient is different, so we come up with this plan with the patient, not for the patient. Okay? All right, so when their symptoms are well controlled, we're going to consider them to be in the breathing zone. We first need to figure out what is our peak expiratory flow using a peak flow meter. So that device on the bottom, the peak flow meter. When they are in their best state, most controlled, no symptoms, no triggers, everything is going well. We want to figure out what is the best that patient can do. What is PEF for all PFTs? What is the units of measurements? Liters. Just liters. Okay? So we want to figure out what their best is. And then 80%, greater than 80% of that is going to mean that they're in the green zone. Okay? So we're going to figure out what is 80% of their best, and then greater than that. That is the goal. The goal is to always be in the green zone as often as possible. That doesn't always happen though, because you have triggers, you're outside, you have a lot of other things going on. So sometimes if their symptoms are more frequent, they'll be in the yellow zone. So this is 50 to 80% of their best. We're going to use caution. We're going to follow that as an action plan, but we need to be careful, slow down, make sure that we're being adherent to the medications. When the symptoms are worsening pretty quickly, we find ourselves in the red zone. This is going to be anything that is less than 50% of their best. This is when they're going to use their rescue medication and seek medical attention. And seek medical attention. Don't just use the rescue and sit down. Rescue and seek medical attention. Okay? So short term, when do we use it? Short term after an exacerbation to make sure are they getting back to their green zone. After we change the treatment, same thing, are we maintaining the control we had before? If the symptoms seem to be excessive, or if we're trying to assist in the identification of triggers. So maybe they're like, no, I don't have allergy. Maybe they did it, and they do. We're going to find out. Okay. Long term, this is going to help us to early detection of exacerbations. So if the PEF is going down, we can get in the yellow zone and stop with the yellow zone. Usually that's not an exacerbation. We save the patient from that. Usually this is in patients who have a poor perception of how well they're doing. So some patients think, oh no, I'm doing fine. No, you're at 60% of your best, and we need to do something about it before it gets worse. Okay? Patients who have a history of sudden or severe exacerbations. Maybe that trigger really triggers and they're in the red zone very quickly. Also, the patients who have difficult to control or severe asthma. So we are thinking, why do we use a peak flow meter? Why do we give it to the patient? Why do we educate them to pay for it? It's not covered. The one-time fee, use it for as long as you take care of it. Usually it's in the $25 to $40 range. Okay. So, green zone, 80 to 100% of their best. We're going to continue the therapy as prescribed. We're not going to make any changes. Okay. On this part of the chart, it also gives them some examples of what the green zone may feel like. So breathing is easy, there's no coughing or wheezing, they can work and play as normal. So we're going to put the instructions on there, but we'll do that as a knowledge check. Yellow zone, 50 to 80% of their best. The easiest thing to do is to calculate what the yellow zone is, and then green is greater than that, red is less than that. Okay? Save yourself the extra time. With this, they do not feel good. They're coughing, they're wheezing, it's hard to breathe, they're waking up at night. They can do some activities, but not all of them. So we're going to give them instructions on how to adjust their medication at this point. And this is going to be based on their symptoms as well as the number. So sometimes, this is a plan that we could consider, we're going to increase the reliever use. In quotes, it's how we may increase the use. But in the yellow zone, we're always going to increase the use. We're always going to increase the ICS dose temporarily. Okay? So it could be that we'll schedule the dosing for the reliever for 1 to 2 days, and then we'll double the ICS dose for 7 to 14 days. That is going to be up to the provider and or the pharmacist who are developing that with the patient. Okay. This would be appropriate if the PEF has fallen by 20% in 2 days or in 2 days. But generally, it's just once you're at that less than 80%, let's just try to get you back to 80% on that. Okay? So everything in quotes is an example. You just need the yellow part. Increase reliever, increase ICS dose. Good? All right. The red zone is going to be when our symptoms are worsening rapidly. So we're already at less than 50% of the best. Rescue plus seeking medical attention. At this point, the medicine doesn't help. So we're really relying on that lava in their march or the sava that we have to sustain them until they get to that medical care. Okay? Breathing is hard and fast. It's hard for them to walk. It's hard for them to talk. And at that point, a lot of patients feel pretty scared. This is when you hear, like, it's an elephant sitting on my chest, or you usually hear at that point. Okay? Again, we're going to increase the ICS or increase the reliever. That should actually say discontinue or hold the ICS dose because at this point, the ICS is not doing a lot for us. However, after discharge, we are going to increase the ICS, so they'll still be in the red zone, but they might be working their way back up to the level. At this point, we may also consider initiating oral corticosteroids. So sometimes with the asthma action plan, we write a prescription or the provider will write a prescription for a dose pack that they hold on to, and if they find themselves in this area, they will be provided instructions on how to do that as well.
Yes, so in that And if the patient is in the red zone like currently, we hold the ICS and then we initiate it after the patient gets better.
Correct. But at that point, we're always going to step up therapy. So that's kind of like a temporary increase in the ICS until we get a full knee regimen. Okay. With these OCS, so patients who are 12 and older are going to be prednisolone 40 to 50 milligrams per day for 5 to 7 days. I would know that person, just as a pharmacist. You can also consider prednisone. It doesn't have to be prednisolone, but what dosage form is prednisolone in? Okay. A liquid. Okay. Prednisolone is a liquid, prednisone is an oral solid tablet. So depending on how old the patient is, if they can swallow tablets or not, that's how you'll pick between prednisone and prednisone. But either way, 40 to 50 milligrams a day for 5 to 7 days. For 6 to 11, prednisone 1 to 2 mg per kg. So you just need to know that oral corticosteroids are weight-based dosing in pediatric patients. Say again?
I suggest prednisone.
You can also use prednisone. It should be in the notes of the slide with the asterisks. But prednisone, typically. And these are useful in patients who respond to that increase in therapy for 2 to 3 days. Because they're not always going to the emergency department. They can go to urgent care, they can go to their doctor's office. So sometimes we're not going to do all of what we're going to talk about in a bit. It just depends on where they go. These are also for patients who are deteriorating rapidly or, again, have a history of sudden and severe exacerbations. That's when we're going to use an OCS as well. Okay? All right, so let's do some calculations. So let's say the patient's personal best is 600. Okay, I like to think of this as a number line that goes from 0 to 600. What is the red zone? Less than 50%, good. What is the yellow zone? 50 to 80. And what is the green zone?
40.
Yes. Okay, so making sure that you know these percentages is going to help you the most. Because you're going to have this question with obviously different numbers. Okay, we're going to practice with these 600s, but making sure we all know how to do the problems. So what is the 50% mark for this patient? 300. Okay, so always start with 50% because that's easy, other than that. So what is the red zone considered? 0 to on top of it, yes. 0 to 299, or you can say less than 300. Okay, every single number doesn't make a difference. It's not going to be life or death. I will make the adjustments as necessary for the exam, but understanding that red is less than 500 or 50%. Okay, so make sure you understand that less than is not less than 82. Okay, so if this is less than 300 or 0 to 299, what is next? So Kingsley was correct. 480 is that 80% marker. So that means that green zone is greater than 480 or 481 to 600. Okay, is this math making sense? So by default, the yellow zone is 300 to 480. Okay? So if we had calculated 50% and 80%, then we know that yellow is equal to 300 to 480. And everything else is greater than 480 or less than 300. Okay? As a pharmacist, this is something that you want more often than the provider. Okay? Everybody got this? Anybody need another second? Alright, so JW is a 28-year-old female who presents to the clinic for an asthma assessment, currently on Symbicort and insulin. We have to get this solved. Come on. Personal best is 440. You decide to be a proactive active student and draft an asthma action plan to present to your preceptor for this patient. Okay, so personal best is 440. We'll give y'all a second to maybe do as much of it as you can. We're going to go step by step. Okay? All right. So the green zone, what would we do? It's 80% of 480. 440, sorry. 352. So what is the green zone considered? Good. So 353 to 440. There is a spot that says peak flow numbers. That's where we would put that in for the patient. They blow their peak flow meter and they get to 400. What zone are they in? Green. Okay, that is a very likely question. The personal best is 440. At home, they blow into their peak flow meter and they're at 400. What zone are they in? Green. Okay. So at this point, they're going to continue to use their asthma long-term control medicine. Notice that this is written in patient-friendly language because this is for the patient. This is not for our documentation. This is not for our SOPA. So we might not have terms like controller therapy. Long-term control medicine. Okay? So that means for this patient, Symbicort and Ventolin should be taken as therapy. Okay, so whatever their prescription regimen was, we're going to take it just like that. No changes. Okay? They're going to take, what medication are they going to take 20 minutes before exercise? Of the options that they have and how they're currently used. Your Ventolin. Good. 2 puffs of that Ventolin 20 minutes before exercise. But that's also part of their maintenance medication or their maintenance regimen. It's pre-treatment before exercise. It's how we're maintaining not getting to infection. Okay? For the yellow zone, what numbers do we have here? Start from smaller to larger. 22, 220 to 352. Because 220 is half of 440, and then the 80% was 352. Okay? So at this point, how much of their quick relief or reliever medication are they going to take when they're having symptoms? What were the directions for the albuterol symptoms? Okay, what were the instructions for their reliever? Okay, so 2 puffs of that reliever therapy. When you think about how to use it in a exacerbation or maybe an exacerbation where they need 2 puffs every 4 to 6 hours as needed. At this point, we may consider that for every 20 to 30 minutes. Okay? We're not going to take more than, if we're not back in the green zone within 20 to 30 minutes, we're going to take 2 more puffs. Because the goal is not to get red. The goal is actually to be in state for real. Okay? So what medication are they taking regularly or for reliever? Their Ventolin. What medication should they continue or maybe increase? The Symbicort. Okay? So for this patient, they decided to continue the maintenance medication as prescribed and increase the reliever therapy's frequency. Okay? But again, every patient is different. So there's never one right answer and one right answer only, except for the numbers for the ranges. Okay? How we doing? For the red zone, what should they be doing? What numbers are they concerned about? Less than 220. So you notice how this paper says lower than slim. So lower than 220. It actually for a range 0 to 219. Okay, semantics, again, that 1 digit is not going to be life or death. If they're at 220 or 221 or 219, I would rather them follow the red regimen than to, oh, but I'm kind of in the yellow. You kind of might die, so let's not risk it. Okay? Alright, and care, that's awesome. So what medication are we taking for reliever? For relief? Ventolin. Should we be taking that Symbicort right now? No. Okay? Because we don't want to maintain the current state that we're in. We want to leave the current state. Everybody good on asthma action plans? As long as you know 50 to 80 for yellow, the rest is easy. Okay?
I have a question about the young. It sounds like increase reliever schedule dosing for 1 to 2 days. So
So you can, but again, it's patient-specific adjustments. So every patient is different. So the question answer options will say something to the effect of consider increasing reliever, consider increasing maintenance reliever. Because sometimes we don't, sometimes we do. If the first asthma action plan, we decide to keep that the same increase reliever and we come back in 6 months, we might be like, okay, maybe we'll try to increase that ICS. But do we want to increase the ICS? Like, that's not really our goal. We want to keep that as low as possible. So for that initial asthma action plan, it might be keep it as is. But if this keeps happening, we need more control. Okay? All right, so primary and or ambulatory care management. So they don't have to go to the emergency department. They're going to save themselves a lot of money and time by showing up to one of these places first. Okay? So what do we need to collect? I want to be an care pharmacist. I want to be a community pharmacist. This is for you. All my hospital pharmacists. This is also for you. History of present illness. What would be part of your HPI for a patient with asthma? What are some things you probably need to put in there? Personal history, frequency of symptoms, onset of symptoms, what are some things that triggered, what medications are you taking, a regular HPI. Okay? Let's do a physical exam. So signs of exacerbation, severity, and vital signs. We'll talk about those vitals in the next slide. Assess for some complicating factors. So do they have anaphylaxis? Do they have pneumonia? Is this also a viral infection? Something that might warrant a little bit more care. Signs that an alternative condition could be explaining this right now. What if you have uncontrolled heart failure? Maybe that's why they're short of breath. So we need to figure out what else could be going on. The objective measurements that we're looking for, a pulse ox of less than 90% warrants aggressive therapy. What is a normal pulse ox? 93 and greater. I'm a 95 and higher person, but okay. So how do we classify the severity of that exacerbation? Okay, are they talking in phrases? Do they prefer sitting to lying? Because if they're lying down, they're subject to the effect of gravity, which is making their lungs feel even worse. Okay, so they're going to tell you, I'd rather sit up. I don't want to lie down. They are usually not agitated yet. Their accessory muscles are not currently being used. So where are your accessory muscles? Sides of your ribs. Okay? At this point, they're not using their accessory muscles to help them to get their lungs to breathe. That's a good thing. We don't want them to need that. Okay? For these vitals, a respiratory rate greater than 20, a pulse of 100 to 120, O2 sats of 90 to 95, and a PEF that puts them in the yellow zone. Okay? If it is severe, they are talking in words. They're sitting a little bit hunched forward. They're trying to do the opposite of the effects of gravity. They are agitated at this point. They are using their accessory muscles, which means their body is basically working a lot harder to continue to breathe. Please make sure that you understand these buzzwords, if you will, because it's going to describe a patient for you, and you're going to have to pick the severity. Okay? Their vitals at this point, their respiratory rate is greater than 30. The normal respiratory rate is 12 to 15-ish. Okay, so once you got greater than 20, you're already in moderate, mild or moderate. Greater than 30 is severe. That means they're breathing very fast. A pulse of greater than 120, O2 sats that are less than 90%, and a PEF that puts them in the red zone. Okay? Life-threatening, they're also drowsy, confused, or have a silent chest. So essentially their body has stopped trying to help them to breathe, which is why it's life-threatening. Okay? Any questions about these? How do we pick the severity of their asthma condition? What is that based on? After 3 months of treatment, what control of therapy are they on? Step 3 and 4 is moderate, less than that is mild, more than that is severe. How to pick the severity of their asthma exacerbation based on their symptoms and their virus. Okay? When I say make sure to read the whole question, read what the question is asking, answer what the question is asking. Things like this is why I always say that. Okay? So, a treatment algorithm for an exacerbation that is mild or moderate. So what type of respiratory rate do you consider this patient to have? Greater than 20, but less than 30. Then 20 to 29, essentially. Okay? So we're going to start with a solid treatment. So even though we said before, we don't really want to use a solid for immunotherapy in an exacerbation, we absolutely do. Because it's going to be short term, we're trying to get in and get out. Okay? So solid treatment, this is going to be 4 to 10 puffs every 20 minutes for an hour. We'll talk about nebulizers in a minute. We're also going to use that oral corticosteroid. In this case, we're choosing prednisolone, but prednisone is equally appropriate if they can swallow tablets at this point. Okay? For prednisolone, 40 to 50 milligrams for an adult. Children is weight-based with a max of 40. So children, weight-based, max of 40. Adults, 40 to 50. Okay. We want to make sure that O2 sats are controlled. So 93 to 95, we will accept. We good so far? So we don't always have to give oxygen because what O2 sat made them mild or moderate to begin with? 90 to 95. So we're just trying to maintain them at the upper range of that. So 93 to 95. If they stay there, we'll leave it. Okay? If they improve, we want to continue that reliever treatment as needed, assess the response in an hour or earlier, because again, we're using that every 20 minutes for an hour. So 2, 4, 6, that's 3 doses. Okay? And then we want to assess if they're ready to be discharged and go home. If they are worsening, either after that hour or in the midst of that, then we are going to consider them to be severe or life-threatening. At which point we're going to transfer them to an acute or emergency care facility, so urgent care, emergency department, one of those. Okay. While we are waiting for them to get there, we want to administer that solid. So we don't want to stop that. We want to consider ipratropium. So what drug class is that? What kind of muscarinic? Long or short? Short. Remember, eyes are short, T's are tall. Eyes are short, T's are tall. So ipratropium is short acting because we are in an exacerbation right now. So we need something that's going to work right now. Okay? So we're going to add ipratropium. At this point, if they're worsening, it's probably also the result of their O2 sats, and we may consider adding that on as well. And oral corticosteroid if tolerated. Sense? Okay. We're going to assess their symptoms. So if they no longer need that solid, then we're good, and we can discontinue that and go back to their every 4 to 6 hours as needed. If the PEFs are improving, so we're just trying to get to like 60% or greater, we're okay to be in the yellow zone. We just don't want to be in red. Okay? 60 to 80% of their best. Their O2 sats are at that 94% or better, and they're able to maintain that on their own. And they have adequate resources at home. They don't have any refills of their ICS. If they don't have any drugs at home, if they don't know how to take it, we need to get that fixed before we send them home. Okay? Then we need to arrange to make sure that their reliever therapy is continued PRN, that their controller is either started, so maybe they just weren't on it or weren't taking it. So we either need to start that or we can step it up from whatever they came in on. Continue that prednisone for 5 to 7 days post-discharge. Check for their inhaler technique, make sure that they're adherent to the medications, and then follow up in 2 to 7 days. Okay, so that post-exacerbation, follow up within a week. Anything less than a week that isn't today, be appropriate. questions you guys have. All right, we're going to take a quick break, and then we'll come back and finish.
That's where.
All right, so case JC is JC is a 16-year-old female well known to your clinic for her frequent asthma exacerbations. Today she presents to the clinic for a sixth visit. Her asthma, her answers to your questions are brief. Remember what type of her vital respiratory rate of 27 and her heart rate of 110. How would you classify her exacerbation severity? Moderate. Okay. So sometimes, even if you don't remember what questions are brief or answers are brief, if you know the vitals, you should figure out the rest. You should never have a patient with an asthma exacerbation and you don't get their vitals. So, cheaper. Okay. You correctly determine her exacerbation severity and want to start treatment in clinic before sending her home. What do you recommend to the attending? A solid, okay. How much and how often?
4 puffs to 10 puffs every 20 minutes for an hour.
4 to 10 puffs every 20 minutes for an hour. What else? How much?
40 milligrams.
40 to 50 milligrams.
And is that a one time?
How old is the patient? 16. So with prednisone, what dosing do we pick for her? Children or adult? Children. Good. We don't have a weight, but what do we know about children's dosing for prednisone? A max of 40. Okay. So remember, when we're talking about the inhalers for treating asthma, 12 and up is an adult. But prednisone is prednisone is prednisone, so it does not matter how old the patient is for the disease. We are going to classify them as our standard child or adult. Okay? So she's a pediatric patient. We do not have a weight. But if it was, whatever it was, you don't know it, but it was weight-based and it's a max of 40, she's probably going to max at that 40 anyways as a 16-year-old. So the answer options are 40 or 50. What would you pick? 40. Okay? Alright, so we have the solid, we have the prednisone, anything else that we need? Consider oxygen. Thank you. We didn't get her O2 sats here. But how much oxygen or when do we want to consider? What's the goal for that oxygen? 93 to 95. So all of this yellow box. Okay? We're going to continue that treatment and reassess within an hour. Does that rationale make sense of how we got to everything we got to? Good. All right. Yes.
Sorry to interrupt. I have a question. So if a patient comes and you get it, the O2 sat, it's and it's less than 90, it's considered an emergency and you have to treat right away.
Correct.
Okay.
We want to take the worst of the vitals and treat for that. Okay. But it's rare that the O2 would be that low and the respiratory would still be okay.
Yeah, I was just if you only had that thing,
you should calculate their respiratory rate while you're waiting for the pulse ox to read. Which is why a lot of times they just let you talk. That's because they're watching you count Ubers. Okay. Emergency management. So now we're getting urgent care and or the emergency department. So where of these options is a patient likely going to present? Which of these severities? Severe. Okay. Hopefully they don't get to us in life-threatening, but sometimes that happens. So, is that why you probably don't have it because you don't need it. But an MDI, so what's MDI? Your dose inhalers are standard, like what people think of when they think of inhaler. These deliver 5 to 50% of the actuated dose. Based on proper technique, we can increase it up to that 50%. The delivery is increased with the spacer. So that tube that we see attached to the inhaler. Just want to disclaimer and defend my people. All spacers are not just for children, adults need to use them too. Okay? A lot of people be like, oh, you're an adult, you don't need a spacer. It increases the delivery of the drug, it absolutely is. Okay? So we're thinking an albuterol MPI is 90 micrograms per cup, so we're only really getting a max of 50% without a spacer and a little bit more with a spacer. Nebulizer delivers 2 to 15% of the starting dose. So y'all are probably like, well, how come they didn't use a nebulizer? Tubes and blah, blah, blah. It only delivers 2 to 15%, and we have 2.5 milligrams for every 3 mLs. So we're probably going to need more and more ampules of albuterol to put into the nebulizer, but we also run that risk of viral infections. Why? Two. Patients aren't cleaning those tubes properly, and all of the germs in the air and whatever they're breathing is in there from the last time, and it sits in a closed up space and they use it again the next time. The way you clean a nebulizer tube is the same way you clean baby bottles. You gotta put them in boiling water and let them do their thing and air dry completely before you put them away. When you're in an asthma exacerbation, nobody wants to do all that when it's over, so they just put it down, and then by the time you need it again, it probably hasn't been cleaned, and I don't have time to stop and clean it before I use it again, so then you just use it. You're increasing the risk of viral infections also. Okay? So when people say, why don't you want to use a nebulizer? You can use an inhaler with a spacer, and it's going to be more effective than a nebulizer in an exacerbation. Okay? Alright, so in this setting, we already got the HPI, or we should have already done the physical exam, we should already have our PEF and our pulse ox. At this point, we are now considering our ABGs, arterial blood gases. Did you guys know? No. Renal. Okay. When you get there, you'll know the ABGs. But we're only doing that in patients whose PEF is less than 50% or they are rapidly deteriorating. Because at that point, we're trying to figure out if they're in respiratory acidosis or alkalosis or compensation. That will make sense. We are also only going to consider a chest x-ray in patients who are having complicating factors to make sure that they are not having a pneumothorax too. Alright, so if it doesn't say that they have complicating factors, if it doesn't say we're trying to rule out a pneumothorax, not need a chest x-ray. That's just another expense that falls to the patient. Alright? So what other things are we considering when we get to an emergency care management? They're considering chest x-ray and EEGs. Okay? Consider plus minus, maybe not. At this point, they should have already been getting that solid O2 stats should already be working towards being maintained. Now is when we're talking about adding on the ipratropium, the systemic corticosteroids, because it's difficult for them to breathe, so it's probably more difficult for them to swallow. So the oral corticosteroid option is probably out. We're also considering IV magnesium and considering high doses of ICS. Generally, it's not. And at this point, we're just trying to do anything we can to keep them from getting worse and help them to get better. Make sense? Any questions?
And moving into the pharmacology of those drugs, we have already seen this classification. There are two things which were added to the bronchodilators. We have anticholinergic or ipratropium, which we have already discussed in clinical slides, and then we have magnesium, which is kind of like an oral formulation. So atropine is where we get the ipratropium from. So more or less, this is kind of like your benadryl alkaloid, which basically gets your atropine from, and then we have your ipratropium, which is kind of like a synthetic form. One of the things which you can observe in this structure is probably this kind of moiety over here, and there's like a quaternary ammonium compound, which is your M, and over here. So this quaternary ammonium compound is one of the hallmark feature of your ectropium. So can you tell me from your chemistry knowledge, compared to a tertiary amine, your quaternary amine, what is the difference? Less soluble or more soluble?
More soluble.
More soluble or less soluble? Quaternary ammonium compound is more soluble. All right. So go back and check that for me. But one of the things which we have to understand is this quaternary ammonium compound has less solubility based on what I have observed. Okay, and that would basically be one of the aspects that this drug will not bleed into your systemic circulation. Because of its less solubility, it doesn't bleed into your systemic circulation, and that way you're not causing other adverse effects in this particular drug. Okay, and again, please correct me if that is not something which is different, because this is directly coming from your text. Coming to your mechanism of action, competitive antagonism of your two receptors, which is cholinergic receptors M3 and M1. As I told you, M3 is in a muscle, M1 is in your mucous glands. What is M1 for? Why do we antagonize mucous glands? To decrease mucus secretion, because asthma is one of the hallmark feature is goblet cell hyperplasia, where there is more mucus formation. So it's going to help with that, and this M3 basically causes bronchoconstriction, so we antagonize that to cause bronchodilation. So GQ is one of the G protein couple mechanism, right? So we have discussed about GPCR divided into three types. We have a GS protein, which is G stimulatory. We have a GI protein, which is G inhibitory. And there is one thing which probably you are also aware of is a GQ protein. And whenever GQ comes to your mind, what you have to remember? It's calcium. Okay, so GQ activation mostly causes release of calcium. Can you control that? It's all involuntary. This is all your sympathetic parasympathetic system. Your body decides when the calcium levels go down, it automatically activates the GQ pathway to take the calcium out from your bones, from your teeth, from your sarcoplasmic reticulum, and send it out into your system and circulation, so that the balance of the calcium is optimal in your system and circulation. How can this basically tie with your asthma? As you understand, asthma is a condition of bronchoconstriction. So if you're going to antagonize this pathway, we're going to reduce the bronchoconstriction. That way it can cause bronchodilation. So if you see this pathway, ipratropium is going to block the GQ protein. That way, the conversion from your actual PIP2 phosphatidyletol bisphosphate cannot be converted into IP3, and IP3 cannot be causing to release the calcium from the sarcoplasmic reticulum. There is less calcium, leads to less contraction. Less contraction leads to elevating the symptoms of asthma. Okay, so first read this pathway without ipratropium, then read the pathway with ipratropium. Okay, so you will have more understanding about it. So normally GQ causes increase in IP3 and DHE. IP3 causes release of calcium from the sarcoplasmic reticulum. What is sarcoplasmic reticulum? It is the reserve of calcium. It's a warehouse of calcium in your body. So it goes into your sarcoplasmic reticulum, it asks calcium to come out so that you basically get that balance. And that calcium will cause contraction whenever you need a contractility. With ipratropium, it blocks all of that, so there's less contraction. And the same is true for mucous glands. So please remember which is which, because there will be one question in the exam from M1 or M3. So don't get confused at that time. What is the function of one or what is the function of three? Because they have distinct functions. Clear? Alright, where does it fit in this pathway? It's over here. Parasympathetic system causes constriction. So if you're going to antagonize this bronchial smooth muscles, you're going to cause bronchodilation over here.
All right, so ipratropium in these settings. What other drug do they also need in this emergency setting? A sabo. So let's get us a combo drug and save us some additional administrations, okay? So we have complement and dual dev. So now we have this HOMO plus a sabo, short-acting muscarinic antagonist plus the short-acting beta. These are also known as anticholinergic agents. So I know you guys have probably already heard that, muscarinic, anticholinergic, et cetera, et cetera. Just make sure that you don't forget it. Okay? Because it's also anticholinergic, what side effects are we thinking about? Dry mouth, dry eyes, dry constipation. Okay? So it's easier for me to remember the anticholinergics do all that because I already know that. And then you guys know anticholinergic equals anticholinergic, then I'm, oh yes, those types. Okay? So now we have ipratropium bromide plus albuterol sulfate. With complement, it's an inhaler. So 4 to 8 puffs every 20 minutes for an hour, and then every hour for up to 3 hours. Yes.
So this is used for asthma as a like exacerbation
An
and
emergency reliever therapy. Okay, so they shouldn't be going home on this on a regular basis.
So I have another question. I know that this was not a drug top to 100. Is it used for COPD in the non-emergency setting?
Yes,
Oh,
as a reliever option. But remember, we said the ipratropium is the only soma that we're going to use in asthma. Okay, and we're going to use it with the solid because we already need the solid too. Okay. In the healthcare setting, you're more likely to see dual death because they are usually going to have one-time use tubes, and you can only use it once to properly sterilize them. We still have that decrease in absorption, so remember that. Advocate for, can we just put them on complement and give them a spacer? You don't need to increase healthcare dollars because now we need 3 mLs, another 3 mLs, okay? Doing at 0.5 milligrams, continuous nebulization every 20 minutes for an hour, and then again every hour for up to 3 hours. Okay? You need to know what is in complement / dual neb. Duo, 2 drugs, neb, nebulizer. That's the nebulizer version. Complement, combo, ventilation. 2 drugs as an inhaler. Okay? We're very clever with brand names. Common side effects: dry mouth, headache, cough, bronchitis, upper respiratory tract infection. I'm going to argue that the URI is from the nebulizer use. Okay. Rare but serious visual halos around lights, close-angle glaucoma, and hypersensitivity reactions. Which is why you want to start them on it as soon as we need to and stop them as soon as we can. Okay. We're going to monitor those pulmonary function tests and the resolution of the exacerbation. That should be the only time that we're using it. Precautions, so understand that it could increase intraocular pressure, IOP, thus the glaucoma. So we just want to be mindful for that, monitor that if they're using it a lot, and then may cause urinary retention. Which drug is causing the urinary retention? The ipratropium. Right? So make sure you understand those class-wide side effects. Contraindications, so hypersensitivity to atropine or any of its derivatives. Ipratropium is a derivative of atropine, so if they're allergic to that, they're going to also be allergic to ipratropium. Okay? Alright, when we're talking about those systemic corticosteroids, oral administration is as effective as IV. If they can take oral. Okay? If both options are on the table, we're going to prefer oral. But if it says they cannot swallow pills or they're NPO, we're going to go IV route. Oral steroids require at least 4 hours for clinical improvement. In this state, 50 milligrams per day is the max for 5 to 7 days, and 40 milligrams per day is the max for 3 to 5 days for children. Okay? Remember, we are not talking about inhalers. Pediatric is what we all know to be pediatric. Okay? Less than 18 over so. Okay? IV is considered if the patient is too dyspneic to swallow. What is dyspnea? Dyspnea. Short breath. Good. If the patient is vomiting, so we're just going to throw it back up and now we have to give another dose. If they require non-invasive ventilation or intubation. Okay? So depending on how they present will determine if you're going to go oral or the IV approach.
It's probably one of the last mechanism slides for magnesium. Magnesium is also known as a calcium channel blocker. So if you can remember that point, I think you should be good. Coming to how it's basically causing that calcium channel block. So magnesium on the calcium channels in the blood vessels is going to block that. That's one way. So less calcium moving into the cell leads to less calcium causes less contraction. Less contraction leads to dilation like phenomena. But another way it basically does is it opens some of the calcium channels. So whatever calcium is inside the cell can also be effluxed out. Okay, so by dual mechanism, one way of blocking excess calcium to enter in the cell, the other one is effluxing out more calcium from inside the cell. That way it's maintaining the tone of the muscle in a way that it is more dilated, and that way it can help in its exacerbation. Right. So here is active learning from the two classes of drugs we discussed. One is anticholinergic and another one is magnesium. So go ahead, read the case. A patient with emergency in the emergency department with severe asthma exacerbation is administered protropium along with albuterol. What is the likely mechanism of protropium which enhances bronchodilation in this scenario? So now we discussed the slide, you got the knowledge, you get the answer. The same should be true in the exam. Okay, I'm not going to ask you anything out of this handout, but don't get confused. Okay, when you read everything together, things will compound. All right, so the answer is B. Okay, very straightforward. It blocks the M3 receptors, and again remember, M3 is your muscle and one is your mucus class. In status asthmaticus, what is this? It's an emergency condition. Unresponsive to beta-2 agonist corticosteroid, IV magnesium sulfate is given, which mechanism explains the potential bronchodilatory effect. B. Blocker of calcium channels. Okay, in various ways. It doesn't have to do anything with beta-2. Nothing to do with M1. Inhibition of eosinophil chemotaxis is a corticosteroid. That's magnesium is not a corticosteroid. It's a bronchodilator. All
right, so how do we use or where and when do we use magnesium? So 2 grams IV once, so it's just 1 dose over 20 minutes. What do you think you probably need to know about magnesium? Yeah, it's IV. That color difference is on purpose. I really am trying to help you. Okay? Children are also going to get an IV. That's all you need. Okay? Because when you think about it in the real world, I have lexicons at my fingertips. You just need to know not to pick the oral option of magnesium in these moments. You can check lexicon to get the actual dose. Okay? The oral efficacy, however, in role and practice, you don't need, which is awesome. It's not recommended for routine use. It's usually more efficacious in children. We're still giving it IV. And the side effects of dose relief. So the more we give, the more likely they are to experience these side effects. So flushing, hypotension, vasodilation, and hypermagnesium, which all make sense and are the same for magnesium across the board. Okay? So ultimately, JC presents to the ED on the following day. She didn't take her albuterol and was unable to pick up her steroids from the pharmacy. So what should we have checked for before discharge? Appropriate resources at home. We don't know why she was it says unable, not she didn't, so maybe she couldn't afford it, maybe she never had time to go. But we want to make sure that we coordinate all of that as much as possible. She presents with a respiratory rate of 32 and O2 stats of 88. She vomited twice in the ambulance on the way over. What is her exacerbation severity? Let me help you a little bit. Severe. Severe, yes. Okay. What treatment do we want to initiate? Confident.
IV corticosteroids.
IV corticosteroids. Why are we going the IV route?
Vomiting.
She's been vomiting. Okay, so keep that in mind. Anything else? Oxygen. Okay. So just because it says oral, they can warn corticosteroid. She was vomiting. If she's not still vomiting, if she no longer feels nauseous, we can consider oral. But if it's too soon to tell, you can also go to IV route. Okay? Alright, so when we're reviewing the response in these emergency care settings, we're going to measure that lung function in an hour. What are we using to measure the lung function? EFTs, which one in particular? We're going to go the whole spirometry route? No. PEF, peak expiratory flow, get that from the flow meter. Okay, they literally just blow into it once as hard and as fast as they can. We figure out, are they at their personal best or what percentage of that they are. Okay. We'll consider hospitalization admission. So admission means we're no longer in the emergency department and we have moved to the floor. Okay. We'll consider that if after treatment her PEF is still less than 60% of the best. Or if we're not getting a clinical response. So maybe they're still having shortness of breath, they're still wheezing, they're still coughing, they still have high respiratory rate, things just, we did everything we're supposed to do, it's still getting worse. Then we're going to consider hospital admission, which makes sense most of the time. Alright? We can consider discharge if after treatment the PEF is at least 60% of their best. Okay, so we're not looking for perfection, we're just looking for improvement. Okay? And the symptoms have to have improved. So it can't just be, they can still get better in the percentage and still have some coughing and some wheezing. Okay, so you may want to hold on, give it a little bit more time. But if the symptoms have improved and their PEF is at least 60%, we can consider discharge. Okay? Medications to put them on for discharge: oral corticosteroids for 5 to 7 days. As needed reliever medication, and initiate or increase their ICS therapy. Depending on where they started, increase that dose, or maybe they didn't start on anything, so you want to start them on something. Okay? Consider some risk factors that may have contributed to this exacerbation in the first place. So we need to identify what they are and then implement some strategies to reduce or eliminate them. Okay? Help the patient figure out how did we get here so that we don't get here again. Self-management, so make sure that we review their inhaler technique. Are they using it correctly? Are they adherent to it? Do they have an asthma action plan? What was one of the top risk factors for asthma-related death? Not having what 3 things? Thank you, Jesse. You have to bounce around you. Sure. I'm the type to wait, so it's fine. So not having an ICS is one, good. Overuse of SABA, one more. Not having a lot of math to figure it out. Asthma action plan. Okay? So not having an asthma action plan, not being on an ICS, overuse of that SABA. Every single patient needs to be on reliever therapy, maintenance therapy, and have an asthma action plan. Okay? Following up within 2 to 7 days of discharge to their PCP. So when you're writing that silk note, talk about anything, and it says, what is the complete follow-up plan? Follow up in 2 to 7 days. With who? Can I just go to the pharmacist at the local community pharmacy and follow up with them? With their primary care provider. Okay? If a patient walked up to you on your appies, oh, I just got discharged from the hospital 2 days ago, they better come follow up. What do you want me to do? Did they send a prescription? Like, want me to fill something? Like, I'm so sorry that happened to you. But, okay, with their primary care provider, make sure that you are clear and explicit. Any questions about discharge? Sure? Any questions at all? Alright, so the case will be posted for you to open up at the start of class. So there's no pre-work to do other than study. Okay? This will give you a chance to figure out how ready you are or are not for the exam. And then based on the case, bring those questions that you had about that to the review on Tuesday. Okay? See you guys tomorrow.